surgical site occurrence, right? So because now ventral hernias are increasingly being performed, the ventral hernia repairs. After these repairs, there are some problems at the operated site. Now they are called as surgical site occurrences, where any complication that occurs at the site of the surgery, which is related to the surgery, but is not infective in nature. Whatever it is, if the patient gets pain at the site, or the wound has got disrupted but not infected, and this wound is not healing, or if there is meshoma, there is collection under the mesh, or if there is seroma, or even if there is hematomas, but there is no infection. This is called as a surgical site occurrence. So seroma, hematoma are more common, meshoma, but if even if there is pain, or if the patient has got ileus post-operatively, or if there is enterocutaneous fistula, but there is no evidence of infection, that is called as surgical site occurrence. Now, surgical site infection, there has to be the presence of the infection, which is bacteriologically confirmed. And this surgical site infection occurs up to 20% of all nosocomial infections. So, all the hospital acquired infections, of it, 20% of them is a surgical site infection. And 60% of these surgical site infections are preventable if proper guidelines are followed. So, if proper pre-op, intra-op, and post-op precautions are taken, 60% of these SSI are preventable. So that is why the amount of SSI happens in a hospital is indicator of the quality of the surgical care that is given in that hospital. Now, how to define it? A surgical site infection is defined as the infection of the site of the incision, or the organ or the space in which the operation has been done, within 30 days of the surgery if there is no implant in position, or up to 1 year if an implant has been placed. Right? You place an implant, it can be up to 1 year. If there is no implant, it is up to 30 days, which is related to the operative procedure. So I repeat, it is the infection of the incision of the skin, or the deeper areas related to the incision, or the organ or space where it has been operated, within 30 days of surgery if there is no implant, or within 1 year if there is an implant that is placed. Yeah. So depending upon where it happens, this CDC has classified these surgical site infections. So according to CDC, the surgical site infections have been classified as a superficial SSI, deep SSI, and then the organ or space SSI. Right? Superficial SSI means the skin and the subcutaneous tissue is involved. Deep SSI means muscle and fascia is involved without involving the organ or space where it is operated. Organ or space infection means it is involving the organ where it was operated, or it is involving the space where it is operated without the involvement of muscle or fascia or skin or subcutaneous tissue. Right. So you need to be clear with these terms. For example, you did a appendectomy for appendicular abscess. The skin and subcutaneous area got infected, that becomes a superficial surgical site infection. If the muscle and the external oblique aponeurosis and internal oblique muscle, they get infected, it becomes a deep SSI. If skin, subcutaneous tissue, muscle, fascia, all of them get involved, it is still a deep surgical site infection. But clinically, there is no skin infection, there is no parietal wall infection, but patient has got intra-abdominal abscess, there is RIF collection without involving the incision site, then it becomes an organ or a space infection. So organ or space infection is the infection at the site of surgery of the organ or the space without involving the parietal layers. If it involves both, then it becomes a deep surgical site infection plus organ or a space surgical site infection. Right. So now CDC has given criteria for this. So according to CDC, if you want to define a superficial or a deep or an organ or space SSI. The first criteria remains same. It is that it has to happen within 30 days if an implant is placed, if implant is not placed, or within 1 year if implant is placed. And it is at the site of surgery and it is related to the surgical procedure with any one of following four. So there are a lot of terms used in the definitions of these four criteria, but when you break it down for practical purposes, it just comes down to this. First is to diagnose this, there has to be a purulent discharge. There has to be a discharge of pus, purulent discharge, and then there is purulent discharge in all the three. But from where? It is from the skin and subcutaneous tissue only. It is from the muscle and fascia. Now, organ space infection is the infection at the organ. So, this discharge will be seen in the drain. Right? You did a cholecystectomy, you place the drain, you see the pus in the drain. So, it is purulent discharge from the drain. This is first. Second is you send that for culture, and the culture is positive, which means that bacteriologically there is infection present. So, you take this purulent discharge, send it for culture, and the culture comes to be positive. And the third is if there is no purulent discharge, there has to be clinical signs of infection. The patient has to have pain, or there is tenderness that is elicited, or there is erythema around the wound, there is increased local rise of temperature. All of these are the signs of the infection. So there are signs of infection present. Here also there are signs of infection present. But here, because it is an organ or a space infection, which is, for example, you did a appendicectomy, there is a pus in the RIF. Now that will not produce local rise of temperature in the abdomen because it has multiple layers to traverse. That is why here a criteria is little changed, which means that either there is clinical or radiological or histopathological evidence of abscess in the deep space, which is either diagnosed bedside or you open this patient and then on exploration you find an abscess. So that is a little change here. And fourth is that the diagnosis is made by a attending surgeon or a physician. So here diagnosis is by attending surgeon or a physician. So it is simple. So at the site of the surgery, 30 days or 1 year, the presence of purulent discharge, and from that discharge you take a culture, the culture is positive. If there is no purulent discharge, but there are clinical signs of infection, and then the diagnosis is made by a surgeon or a physician. So this is a definition for the surgical site infection. Now, what are the risk factors? So there are these risk factors can be classified into three important categories. First is the patient related risk factors, and then operation theater related risk factors, and then the procedure or surgery related risk factors. Now, remember, any deviation from the normal is a risk factor for development of surgical site infection. So, it means that you can add whatever comes to your mind, which is not normal. But if you have to remember, you can remember it as you take the case history. So first would be age of the patient. As the age of the patient increases, the extremes of the age of the patient. In children, the immune system is not well developed. In elderly people, immune system is involuted. So the extremes of the age of the patient. There is no gender bias. And then when you take the present history, already there is a presence of infection. Go surgery for appendicectomy for a clear-cut appendicitis and for appendicular abscess, there is a difference in the infection rates. So already there is a presence of the infection in these patients. And when you take past history, there is previous history of infection. So the patient had undergone open appendicectomy, wound got infected. That infected wound led to hernia. You operated hernia. Now this patient has increased risk of developing infection at the hernia site, no matter however precautions, whatever precautions you take. So if previous history of infection is there, or there's a previous history, the patient is a known case of diabetes mellitus, or the patient is a immunosuppressed individual. So all these are again risk factors. And when it comes to personal history, if the patient is alcoholic and patient is a smoker, both of them increase the risk factor for infection. And when it comes to drug history, if the patient is on immunosuppressants, if the patient is on steroids, patient has taken chemotherapy, patient has taken recent radiotherapy, all of these are the risk factors. And when you examine the patient, if the patient is malnourished or if the patient is obese, both of them, right? BMI of more than 30 is a clear cut risk factor for development of the surgical site infection. If the patient is malnourished, if the patient is obese, or if the patient has anemia on clinical examination, if the patient has ascites on clinical examination. So all these are again the risk factors. Now, when you do investigations for these patients, if the patient is malnourished, obviously there will be low albumin levels. Patient is obese, there is increased cholesterol levels. Patient is anemic, there is reduced HB levels. If the patient has ascites, maybe there is liver failure and the total bilirubin is increased to more than 1 mg per deciliter. So all these are the risk factors. So now you can see that essentially whatever is a deviation from a normal thing from a patient is a risk factor for the development of the surgical site infections. Now OT. So in OT, if there is inadequate sterilization or disinfection, one. Second, if there is inadequate ventilation in the OT, or if there is overcrowding in OT. In teaching hospitals where 20 to 30 students are there in a OT room, so now overcrowding also leads to this. And if there is a breach in ASEPSIS. So all these are the things which lead to increased risk of surgical site infections. Then surgery related. Imagine there's a patient who comes to casualty in the night around 3 a.m. with a penetrating abdominal trauma. This penetrating abdominal trauma will be a contaminated wound. So if it is a contaminated wound or a dirty wound, then there is increased risk of infection. If it is a emergency surgery, then there is increased risk of wound infection. In emergency surgery, most of the times a prophylactic antibiotic would be forgotten. So a prophylactic antibiotic, either it is not given or it is given, but it is not given at right time. So it is inappropriately given. Or this prophylactic antibiotic has to be repeated if the surgery keeps on prolonging for more than 4 hours or the blood loss is more than 1.5 liters. And if that is not given, the second dose of the prophylactic antibiotic is not given, which means it is inadequate. Or at night times, whatever is available that is given. So the proper prophylactic antibiotic is not selected and whatever is available that is given. So not a proper antibiotic. That is again a risk factor. So either it is not given or inadequately given or inappropriately given or not a proper antibiotic is given. This is one. And after that, you induce the patient. When you induce the patient, most of these patients will have hypothermia, as we discussed in the chapter of shock. So if there is hypothermia, or if the patient has hypoxemia, and then if there is a breach in asepsis, so proper gloving is not done, or betadine painting is not properly done. Right? So betadine has a contact time of 3 to 5 minutes. Once you apply betadine, paint with betadine, you need to wait for at least 3 minutes so that it has contacted the organisms on the skin and destroyed those organisms. But you paint with betadine and immediately you pour spirit and rub it off, then again there is no point of painting it with betadine. So that is a breach in aseptic criteria again. So improper painting and improper draping also. So we'll discuss it later in preventive aspects. And next is when you open this abdomen, if there's a lot of blood loss and intraoperatively there is a need for transfusion, again, this can lead to a surgical. This is the risk factor. Intraoperative blood transfusion is a risk factor for surgical site infection. And when you close the wound, if a open drain is placed, this open drain is also a risk factor because it can introduce endogenous, exogenous infection later. So all these are the risk factors, and also most importantly, prolonged surgery is done. And it also depends upon the surgeon. If tissues are handled inappropriately, or when you suture, if there's a lot of tension in the sutures, because this tension will lead to ischemia, and ischemia leads to hypoxia, that leads to necrosis, and necrosis is a good focus for the infection. So all these are the things that are risk factors. Those things which should not be done, if done, they become a risk factor for the development of a surgical site infection. Once a surgical site infection develops, you need to manage it, and also you need to try to prevent it. So that is why you need scores. You need to identify pre-operatively which patients are at a higher risk of developing surgical site infections. The score that is available for this is NNIS, which is National Nosocomial Infection Surveillance Risk Index. So that classification of superficial, deep, and organ space infection was a CDC classification of surgical site infection. NNIS is a National Nosocomial Infection Surveillance Risk Index. It has got three components. The first is the CDC wound class. We'll discuss this again. So if the CDC wound class is 3 or 4, right, which means it is either a contaminated wound or it is a dirty infected wound. Now, this is given a score of 1. If ASA risk score of the patient, which is American Society of Anesthesiologists, if the risk score is 3 or 4 or 5, then it is given a score of 1. And then if T is more than 75th percentile. Now, what this means is if T is more than 75th percentile, so if there is a laparotomy that is being done and 75 people could do it within 2 hours, but you are taking more than 2 hours, then that is the risk factor for development of the infection. So that is essentially prolonged surgery. Okay? So where you take more time than the 75 people who are doing the surgery, or you take more time than 75 times the surgery is being done. Right? So that is called as T more than 75th percentile. That is given score of 1. So total score would be from 0 to 3. 0 is least risk, 3 is highest risk. So this is a risk index for those patients who could develop these infections. Now we need to understand what is ASA risk and what is CDC wound class. So this ASA is applicable for all surgical procedures, be it emergency or elective. You need to score these patients depending upon their performance status and comorbidities. Now imagine there's a patient who is totally normal. This person later developed hypertension, and later, as a consequence of long-standing hypertension, he developed coronary artery disease where there were blocks in the heart. And later, because of these blocks, this patient developed myocardial infarction, which reduced the EF ejection fraction to less than 25%. Now, if you want to grade this, this is a normal individual. Here, there is hypertension, but it is well controlled. So, it is a mild systemic disease. Then, coronary artery disease is a severe systemic disease if the blockage is significant. But if the EF is 25%, the patient can die at any time, even if he is subjected for operative procedure, even if it is not subjected also, it is a constant threat to his life. So remember, ASS score does not start with 0 because there is some risk. Even if you do operate on a normal patients, you give anesthesia to the normal individuals without any comorbidities. So this normal individual here is actually without any comorbidities. Things which are not related to the surgery. Like if the patient has got inflamed appendix, apart from that, he does not have any other diseases. So in such patients also, if they are totally normal, apart from the surgical disease factor, still there is some amount of risk associated. That is why it doesn't start with 0, it starts with 1. So without any comorbidities is 1, a mild systemic disease is 2, a severe systemic disease is 3, and a disease which is a constant threat to his life is grade 4. And unfortunately, if if an individual is going in a car, he got into an accident, there was a blunt abdominal trauma, he had got grade 5 splenic laceration. Now, such patients, no matter what his comorbidities are there, if you do not operate, he will definitely die. So, even if he is a normal individual without any comorbidity, or even if he has a comorbidity which is constant threat to his life, if you do not operate, those patients will die. And such patients are given a score of 5. So these are moribund patients where you do not operate, the patients will eventually die. So that is 5. And if these patients are brain dead, but yet these patients are put on life support so that their organs can be retrieved, then that is called as 6. Right? 5 is moribund patients in whom you do not operate, they will eventually die without the surgery. And 6 is for brain dead patients who are put on life support so that their organs can be procured. This is ASA grade. Then you do surgery, you go to ward rounds. Next day, you need to assess the wound. So, and you grade the wound. That is called as Southampton wound grading. This Southampton grading is for wound healing and infection. Because once you know the risk factors, you need to know if this patient with the risk factor has really got an wound infection or is he going to develop an wound infection or not. So every day in the wards, you grade this wound. So first is you see that it is totally normal. Wound is healthy looking. And next day you go and see there is mild redness. And patient complains of pain. In the evening, you open the dressing and see that there is severe erythema. You try to manage it conservatively, but next day morning, you see there is some amount of serous or there is serosanguinous discharge. And then the next day, there is frank hematoma or pus. Right? So this is what is Southampton grading. So because it is grading of normal wound healing, it can be normal, and that is why it starts with 0. So 0 is normal wound healing, 1 is mild erythema, 2 is severe erythema, serous or serosanguinous discharge is 3, hematoma or pus is 4. So this is Southampton grading for wound healing and infection. And then there is one more grading which is called as ASEPSIS score. So this is the patient has got a wound infection and you want to know the prognosis. For that, it is a ASEPSIS score. So it is ASEPSIS. So A will discuss a little later. So in these patients, if there is a serous discharge from the wound from day up to day 5, first 5 days, in the first week, right, it is called as S. S stands for serous discharge from day 0 to day 5 in the first week. And E stands for erythema. P stands for pus is drained, purulent discharge from the wound. And S is separation of the tissues. So there's a wound dehiscence. And I stands for you sent for a culture and the culture could isolate the bacteria. So it means that it is culture positive. And because of all these reasons, the patient had to stay for more than 14 days or 2 weeks in the hospital because of infection. Right? The infection compelled the patient to stay in the hospital for more than 14 days. Right? Now, A can be either A is actually standing for additional treatment. When you see that the wound is infected, you either start the patient on antibiotics or the pus is not draining, you drain the pus. And then when you drain the pus, you see that there is an underlying necrotic patch that is present and you debride. That is what A stands for. Additional treatment, antibiotics, you drain the pus or you debride. S is for serous discharge. E for erythema, P for purulent, S is for suppression of tissue. All of these are up to first 5 days in the first week. Then culture is positive, then stay more than 14 days. So the antibiotics is given a score of 10. The drainage of pus is given a score of 5. And when you debride, it is also given a score of 10. A serous discharge for the first 5 days is given a score up to 5, meaning no discharge, 0. First day discharge comes 1. Second day also comes 2. Third day also comes 3. Fourth day also comes 4. Fifth day also comes 5. So maximum is 5. And then the erythema is also given the same score up to 5. But these three, PSI, remember it as police sub inspector, so it is given a score of 0 to 10. It means every day you need to add 2 score. Right? So this is 0 to 10, this is 0 to 10, and S is, or I, isolate is also 10, because you could able to isolate the bacteria. There is a clear-cut evidence of infection, so that is 10. Now stay more than 14 days, it is given a score of 5. If you are unable to remember this scores also, it is fine, but these things could be remembered. Once you give all these scores, you calculate and you get a score of, if it is 0 to 10, or it can be 11 to 20, it can be 21 to 30, 31 to 40, or it can be more than 40. So if it is 0 to 10, it is still considered to be a normal process of healing. If it is 11 to 20, it is disturbed healing. If it is 21 to 30, a mild infection. 31 to 40 is moderate infection. More than 40 is severe infection. So every time you just keep on escalating it. Normal healing, disturbed healing, mild infection, moderate infection, and severe infection. So this is about a sepsis score. The last of this course would be a CDC classification of Center for Disease Control classification of surgical wounds. Now, they have classified these as class 1, class 2, class 3, and class 4 wounds. Class 1 is a clean wound. Class 2 is clean, contaminated. It is contaminated, yet it is clean. Class 3 is a contaminated wound. And class 4 is a dirty or infected wound. Right? So what do you mean by clean wound? Clean wound means there has to be no infection. There has to be no inflammation. And even if you place a drain, the drain has to be a closed drain. Right? So there is no signs of infection, there is no signs of inflammation, and you don't have to place a drain. Even if you place a drain, it has to be a closed drain. If you use a prosthesis, right, like a mesh PTFE stent. So if prosthesis is used, it is called as class 1D. D means device. So if any external device is used, it is called as a class 1D. Right? For example, you do a breast surgery, you do a thyroid surgery, because in breast surgery, placing a drain is a part of the surgery. So you place a drain, but the drain has got a closed system. It is a still a clean wound, right? So that is a clean, and GURG is not entered, which means genitourinary, respiratory, and gut is not at all entered. You do not operate on these tracks, right? So you do not enter genitourinary, you do not enter respiratory tract, you do not enter the gut tract. So it is tract. For example, you do a hernia surgery and the content is bowel. But if the bowel is healthy, you are not going to enter inside the bowel. You just push the bowel inside and you place a mesh over them. So that is why a hernia, a breast surgery, a thyroid surgery, uncomplicated hernia. So all of these are considered clean wounds. And where there is no infection, there is no inflammation, even if a drain is placed, it is a closed drain. Now, a clean contaminated is where GURG is entered. Right? So either a genitourinary tract, respiratory tract, or GIT is entered, but it is entered under controlled state. For example, you think that there is a cyst of a small bowel. So there's a tumor in the small bowel, which is not causing bowel obstruction. So you plan these elective cases, you apply clamps on the either sides, you resect that tumor, and then you do anastomosis. Some spillage might happen, but it is the spillage that is happening intraoperatively, so you have control over that spillage. So even if there is little contamination, it is controlled, and yet there is no sign of inflammation and there is no sign of infection. This is important. And these clean contaminated wounds might have minor breach in asepsis. There could be minor breach in asepsis. Sorry, there is, if there is inflammation or infection is there, that is not major and there is no discharge of the pus. So a contaminated wound means you are entering these cavities but under uncontrolled condition. So the patient had got a bowel obstruction and this turned into a gangrene. Now you open it, all the necrotic fluid will come out. So now that is a contaminated wound. Or if the patient had obstruction, you applied clamps. The moment you release the clamps, all the bilious material fell into the abdomen. Or if there was a perforation of appendix, or there was a perforation of the stomach, there was perforation of the gallbladder, all these conditions where the contamination happens in uncontrolled manner. The contamination has already happened before you open the patient, right? It is pre-operative contamination only. That is first. Second is there is major break in asepsis, meaning as I told you about emergency room thoracotomy, right, where you need to do open the thorax. Now it is done in the emergency room, so proper precautions are not taken or open cardiac massage. So there is a major break in the asepsis. And third, they are highly infected or inflamed, but yet there is no pus there. So dirty infected meaning either it is a open wounds or there is frank pus that is present or there is fecal contamination. All of this come under dirty infected wound. Right? So this is about clean contaminated and dirty infected wounds. Now in these wounds, in class 1 wound, if you give antibiotic prophylaxis, the chances of post-operative infections are 1 to 2%. Even if you don't give also, it is still 1 to 2%. So it means that you don't have to give a antibiotic prophylaxis in a class 1 wound. In a class wound, two, second wound, and third and fourth, you give antibiotic prophylaxis, the infection rates are around, even with prophylaxis, infection rates are around 3%, 6%, and 7%. But if you don't give it, it becomes doubled, that is 6%. It becomes tripled, around 18%. This becomes around 6 times, which is around 40%. So this is the easier way to remember. In class 1, doesn't matter you give or doesn't give, it remains 1 to 2%. Class 2, 3, 4, you give, it is 3, 6, 7. And if you don't give, a class 2 doubles, a class 3 triples, and a class 4 becomes 6 times more. So that is why for this, not required, these three need antibiotic prophylaxis. Now, these are all the scores. When it comes to managing, if surgical site infection has happened, how do you manage? So the first principle is you isolate the bacteria. So you send a culture whenever you take a swab, always, wherever it is, if there is a suspicion of infection, there has to be 3 swabs that are taken. The first has to be sent for gram staining, and one for aerobic culture, one for anaerobic culture. You send them. And once you take a swab, you start them on empirical antibiotics. And after you get the culture sensitivity results, try to rapidly de-escalate these antibiotics and give a specific antibiotic to which it is sensitive. And fourth is you need to have a source control, meaning if there is a superficial site infection or there is a deep site infection, open the sutures, let all the pus drain out, and give a good irrigation with saline and antiseptic solutions. And if needed, you debride the tissue. So whenever on wound inspection, if there is a suspicion of abscess or if there is an abscess that is strained, try to open the wound and let it out. If you do not adequately open the wound. If pus cannot come outside, it finds a way where it can spread easily, and fat is a place where it can spread easily. So it will spread in the fat planes, it will spread to facial planes, and it will lead to the dehiscence of the underlying muscles. So if you don't let it out, it spreads inside. That is why whenever there is a pus, you let it out. And once you drain the pus, you debride the wound cavity. There are two schools of thought about packing. So, for example, if this is a wound cavity, whether you need to apply just a gauze piece over this and you do not pack this wound, or you need to pack this wound. So, the older school of thought is that you don't have to pack the wound because whatever collection is there here, it will just come out of this surface. Packing will prevent the secretions from draining. But the newer school of thought is that when you pack it with a gauze piece, these secretions will come out through this gauze piece via the capillary action. So the newer school of thought tells that always pack the wounds with a gauze piece soaked in either a normal saline or an antiseptic solution, and the secretions come out through the capillary action. But if it is an organ or a space infection, now you cannot let the pus out. Right? If there is a RF abscess post appendicectomy, you do a CT or USG guided aspiration if it is amenable. Right? If the collection is at only one point, it is not between the bowel loops, it is not multiloculated, and it is accessible by CT or USG, you do a CT or USG guided aspiration. But if it is not the case, if it is at the multiple places, if it is in between the bowel loops, then you can give a laparoscopic wash. When laparoscopic wash is not possible, you can give a re-explore the patient and give a wash. And then the fifth point would be wound care. Right? And the use of WAC once all the infection has subsided is very good in controlling this surgical site infections. So these are the five principles how you manage a surgical site infection. Right? You can elaborate each of these points. Then is the most important topic, how to prevent surgical site infections. Prevention starts when the patient comes to OPD. So, because this is a nosocomial infection, hospital acquired infection, you try to reduce the duration of the stay of the patient in the hospital. So, lab procedures are very good compared to open procedures whenever possible because the recovery is better, the length of the skin incision is very minimal, and the patient does not have to stay for a long in the hospital. So all of these are protective factors from the surgical site infection. So whenever possible, if feasible, a lab is always to be preferred for a open surgical procedure. So this is first. Second is you try to get all the investigations and all the fitnesses on the OPD basis, and you try to admit the patient a day or the night before surgery. So this is not practical in most of the government institutions, but wherever it is possible, you try to get all the fitnesses and investigation on OPD basis and you admit the patient a day or night before the surgery. And third is when these patients are admitted, iatrogenic infection spread should not happen. So after you examine one patient and you move on to examine the next patient, try to use a alcohol rub, which has at least 70% of ethanol. So hand sanitization of the healthcare workers is important. And fourth is optimization of the conditions. So if the patient is malnourished and you are planning for an elective surgery, try to improve his pre-op albumin levels. Post-op albumin transfusion, unless the patient has hepatorenal syndrome, is more harmful than it is useful, right? So better to try to improve pre-op albumin levels of the patient. And second, if the patient is alcoholic or smoker, abstinence from alcohol or smoking at least 1 month prior to surgery. It should be at least 1 month prior to the surgery. You manage the diabetic, hypertension, and all the comorbidities of the patients. So whatever the patient risk factors were there, you can list them all, and you try to optimize these patients. And fifth is pre-operative bath. You try to ask all the patients to take a good full body bath with a shower if possible, either with a antimicrobial soap or a normal soap is also fine. So either the previous night or on the day of the surgery, early morning, ask the patients to take a good bath with special attention to the area of the interest. And sixth is you try not to shave the patients. In this era, lot of commercially available trimmers and clippers are there. So try to stop the conventional method of shaving with a blade because that can cause the abrasions and that can make the skin commensal in an unprotected environment enter into the deeper wounds. So in this era, it is better not to shave the parts for part preparation. Try to use trimmers or clippers, which are both commercially available. So this is pre-operatively optimization. Now, intraoperatively is first you take the patient into the OT. OT has to be such that there is a laminar airflow system so that modular OTs are very good compared to the conventional OTs. And there has to be adequate ventilation. It has to be adequately sterilized or disinfected. And the order of posting a case is important. So now you have a hernia and you have an amputation. It is a common sense to post hernia first and then amputation in the OT. Or try to keep the septic cases in a separate OTs. So the order of posting the case is important. And then try not to overcrowd the OT. And the strict asepsis has to be maintained in all the aspects. And then you took the patient into the OT. The patient is on the OT table. Now it is time for induction. When you induce the patient, try to maintain normothermia. One, try to avoid hypoxemia to these patients because these two are the risk factors. So try to maintain normothermia and try to avoid hypoxemia in these patients. And if you can avoid intraoperative blood transfusion, try to avoid intraoperative blood transfusion. You can transfuse them post-operative. And then you scrub. So when you scrub for the case, first is you need to use a antiseptic solution. Right? So that is a betadine solution. Betadine comes in different forms. The 2% is a mouthwash, or you get an ointment with 2%. Then there is 5% of betadine solution. The scrub is 7.5%, and 10% is again an ointment. So of this, ideal thing to be used is a 7.5% betadine solution. But if you have eaten or if you have gone to the washroom before the surgery, you need to pre-wash with a soap first, right? Either with a soap or a liquid, water, antiseptic liquid, you need to pre-wash and then you wash with a betadine scrub, right? At least this is all the universal precautions of the hand. Universal precautions of washing have to be followed, and you wash for at least 3 minutes. You need to spend at least 10 seconds on each step, and you need to wash for at least 2 to 3 times. The procedure has to be repeated for 2 to 3 times and spend good amount of 3 minutes in washing. So once you wash the hands, you need to wash the elbow also. And when you wash the elbow, so this has to be in a spiral manner. You take the other hand and you go in a spiral manner up to the elbow joint and you do not come back. Right? It is just one time from here to here in the same direction and you do not come back, and the water has to flow from this direction. And if possible, try to use a foot pump instead of a hand handle for the washing. So this is you wash. And when you wash, you come and you wear the gown in a aseptic manner, and then you wear the gloves. Right? There are two methods of wearing the gloves. One is open method, one is closed method. So you can either wear it by open or closed method, and you stand in front of the patient. But if you have got a cut or an abrasion or an injury over the hands, try not to wash for the case. If you have done a dressing of a septic case in the ward and have come to the OT, try not to wash for clean cases. If there are any ornaments on your hands or wrists, try to remove them before scrubbing. So these are the precautions that you need to take. And then you give prophylactic antibiotic to the patient. So there are guidelines about this use of the prophylactic antibiotic. First is a class 1 wound does not need antibiotic, but if it is a class 1 wound and you are placing a mesh or a stent, then it needs a prophylactic antibiotic. So, for example, if there's a hernia, you just do herniorrhaphy, it does not require a prophylactic antibiotic. But if it is a hernioplasty, you need a prophylactic antibiotic. Right? So, a class 2, a 3, and 4 definitely need antibiotic. Now, when to give this antibiotic? See, Bailey tells that you give an antibiotic at the time of induction. But Schwartz tells you give antibiotic just prior to skin incision. But the consensus is that, and the simple logic is that before you give a skin incision or at the time of skin incision, the antibiotic has to achieve proper levels in the body. Now, if you just give it before the skin incision, it will not achieve proper levels. So the ideal time is you give 30 minutes before skin incision, which usually corresponds to the time of the induction. That is why Bailey tells that it is at the time of the induction. So you give 30 minutes before the skin incision, but not more than 60 minutes. More than 1 hour is not effective. So you give 30 minutes before the incision, but not more than 60 minutes. This is first. Second is when you give an antibiotic, if the surgery is for more than 4 hours or if there is a blood loss of more than 1.5 liters, you repeat it. Second dose. So you repeat the second dose if the surgery is prolonged to more than 4 hours or the blood loss is more than 1.5 liters. And third, what antibiotic should be given? For most of the diseases, most of the surgeries, cefazolin 2 gram IV is the prophylactic antibiotic of choice. For most of the diseases, because it is the Staph aureus, which is the most common cause, and then Streptococcus epididymis, and then comes the gram negative. So cefazolin covers all of them. So cefazolin is the prophylactic antibiotic of choice. 2 gram IV is given. If the weight of the patient is more than 120 kg, you switch it to 3 grams. Right? If it is gut, then you combine a cefazolin with metronidazole. Right? Metronidazole, 400 mg, 500 mg has to be given along with cefazolin, or you can give a ceftriaxone, 1 gram, along with metronidazole. So give a prophylactic antibiotic, and then you start to paint the patient. So again, when you paint the patient, there are certain guidelines that you need to abide by. So first is you paint it with a betadine or with a chlorhexidine, whatever is available as per institutional policy, and then you paint with something which has got alcohol based. When you paint, the first rule is if there is no wound, if it is a clean case, on the skin there is no wound, you always go from, if this is the site of the incision, you always paint the incision site and then you go lateral. But if there is a wound here, you start from the cleanest area and you go towards the wound. And for the wound, you use a separate gauze piece. But if it is groin or perineum, you go from the lateral aspect towards the center. Right? The simple logic is that you paint from clean area to unclean area. So for groin and perineum, you go from lateral to medially. For clean wounds, you go from medial to laterally. And if wound is present, then you go from away from the wound towards the wound. And for the wound, you use a separate gauze piece. Second is when you paint an area, if this is an area, you paint, for example, first time you started with here and you painted all this area. So this area was painted from here to here. Make sure that there are no windows, that is first. And then you rotate the gauze piece and you paint onto the opposite side. This is the first area which is painted. When you paint for second time, this should be lesser than the first area which is painted. And when you paint for third time, it should be either only on the incision site or a lesser area than the third time, right? So if this is the first area you paint, so much of area is painted. When you paint for second time, you leave at least 2 centimeters on the either side and you paint a lesser area. And then the third time, it is either only the incision site or it is these three areas. This is inside the first area. Right? So you progressively decrease the amount of area that is painted. And third, once you paint with betadine, do not immediately put spirit onto that and paint it off. Because when you immediately put spirit onto that, the betadine's contact time is 3 to 5 minutes. So you need to at least wait for 3 to 5 minutes before you paint it with spirit again. Otherwise, it will be of not any use. So that is why you paint, then you drape, you arrange all the tubings. By that time, 3 to 5 minutes will have been passed, and then you can paint it with a spirit. The next point would be draping. See, the standard protocol when you drape is, so if this is a operating table and this is head end, this is patient lying there, and this is the site for your operation. So the first thing is you need to drape with a whole towel that is single, you need to drape it with a towel which is single that will cover entire OT table. Then upon that, you need to put a double towel. Then you put a towel on the upper hand. You can either leave the face open or you can use it as a screen between the anesthetist and the surgeon. Then you put side drapes. Right. So first is a single towel that will cover whole of the OT table till it touches the ground. And then there is a double towel on the inferior aspect, and then a single towel on the superior aspect, and then two side drapes. And once you do that, once you paint, so if this is the abdomen and you are painted with betadine, and this is the area that is draped, right? So this all area is draped. Now this is the only area where you need to operate. Now you paint it with spirit only in this area. The spirit with spirit, you need to paint it in the area which is visible in between the drapes at the site of infection, at the site of incision only. And you do not wash it off or with a gauze piece. You let it air dry. You wait for some time, you let it air dry. And then before using cautery, make sure that all the spirit is gone, or else it can lead to the burn of the patient, or it can OT table or all the drapes and tubings can catch fire. So this is once you drape, you open, and while doing surgery, so you need to make sure that you handle tissues properly, and there is no try to prevent contamination as much as possible, and then there should not be any tension, right? Always try to use interrupted sutures wherever possible. If you want to put continuous sutures, unless there is a bleeding, do not put interlocking sutures, because interlocking sutures again reduce the blood supply, that leads to ischemia, that leads to necrosis, and is a potential site for infection. So try not to put sutures with tension, right? You can still leave the wound open and suture it later, which is better than putting sutures in the tension. And there is one more thing, which is not actually a guideline, but there's a study where you do a surgery laparotomy, and before closing the skin and subcutaneous layer, if you just change your gloves, that will have reduction in 30% of the surgical site infections, right? So once you close the rectus sheath, you try to change the outer gloves, so that will reduce the infections by 30%. So taking all these precautions would help in reduction of the surgical site infections. Right? So this is all about surgical site infection.